Hey guys, it's McKenna, and today we're going to talk about cervical dysplasia. So, cervical dysplasia is a precursor to cervical cancer, meaning that it leads to cervical cancer. Cervical dysplasia is primarily caused by the human papillomavirus, which is a common STI called HPV. In particular, 50% of cervical dysplasia cases are going to be caused by the HPV type 16. A patient's pap smear is usually the first that's going to show some abnormal cells, which leads to a diagnosis of HPV. The persistent HPV infection is going to be what leads to our cervical dysplasia, which, if untreated, can progress to cervical cancer. HPV itself has a very slow progression. Usually, our bodies can treat it on its own, but it can be treated if caught early, which can prevent cervical dysplasia. Which this is why it's so important for patients to adhere to like routine screenings with pap smears and testing to prevent cervical dysplasia. So, some risk factors of cervical dysplasia are going to include some high risk sexual behaviors. This can include multiple sexual partners or a partner who has multiple sexual partners. That's significantly going to increase our risk of exposure to HPV, which can lead to cervical dysplasia. Even exposure to sex at a young age is going to increase our risk and persistence of HPV. The HPV virus, which is what's going to cause our cervical dysplasia, is transmitted through skin-to-skin contact, most commonly through sexual contact. Non-sexual transfer can occur, however, the transmission is typically seen with some sort of like genital and sexual activity. The most like prominent age for HPV infection, which leads to cervical dysplasia, is women 18 to 30 years old. The prevalence of HPV is going to sharply decline after the age of 30. So just a few highlights or high points and key components of cervical dysplasia. It is a precursor to cervical cancer, as we've already talked about. It's caused by HPV. Screening and management of the HPV are best managed by an interprofessional team. So this is going to include our doctors, our women's health nurse practitioners, the family nurse practitioners, primary care provider, a pathologist, a gynecologist, nurses, medical assistants. It's going to take a whole team to diagnose and treat this patient. There are different degrees of cervical dysplasia, and treatments are going to vary on the degree, which this is going to be something that we talk about later in the presentation. The key for cervical dysplasia is for the healthcare provider to recommend positive lifestyle changes and for patients to get vaccinated against HPV. This is going to significantly decrease cases of cervical dysplasia, and we'll talk about this later. So just a few signs and symptoms of cervical dysplasia, and this actually came from the Cleveland Clinic. But cervical dysplasia usually doesn't present with symptoms. Most women who have cervical dysplasia find out they have cervical dysplasia after they've had their routine pap smear, which is, again, why it's so important for routine screening to happen. Most women, if they do have symptoms, are going to suffer from pelvic pain, pain with intercourse. Women are going to complain about abnormal vaginal bleeding, spotting, an increase or change in their vaginal discharge, periods being more consistent, periods lasting longer than they usually do. Anything like that is going to lead us to thinking this woman has possibly cervical dysplasia and HPV. So, diagnostic testing, obviously the most common way to identify any type of cervical dysplasia or abnormality is going to start with a pap smear. Pap smears are liquid-based type of cytology that are going to identify normal and abnormal cells. Our next step in evaluation is going to be a colposcopy. So during this procedure, the cervix is going to be examined with a microscope, and 5% acetic acid is going to be applied to the cervix, and this is going to help to identify abnormal areas. And actually, dysplastic areas are going to turn like a whitish color which is going to be able to identify exactly where this is going and exactly where this is at. If indicated or needed, a biopsy of any abnormal areas can be done and sent to a pathologist who's going to be able to identify any evidence of cervical dysplasia and, most importantly, any evidence of like cervical carcinoma or other cervical cancers. And if you look to the picture in your right, this is actually a cervix. And if you see that little like square with the triangle on top, that's actually what they used during a pap smear to go around the cervix and collect the cells and test the cells. So let's talk about some treatment options. As I said earlier, there are different degrees of dysplasia. So the cervical dysplasia specimen can either be a low-grade squamous intraepithelial lesion, or it can be a high-grade squamous intraepithelial lesion. So the low-grade squamous intraepithelial lesion, LSIL, is going to be classically referred to as CIN1, which is going to be a type of mild dysplasia. This type does not require any treatment, but we want to closely follow this and monitor this because obviously we know if it goes untreated, they can progress and lead to cervical cancer. So patients with LSIL, or the low-grade squamous, they're going to return in 1 year for follow-up testing. And so this is going to involve like a repeat pap smear with HPV molecular testing. And we're going to see that most of these lesions or abnormal cells are going to regress on their own. And then once you get like a pap smear that is like negative for any type of like abnormal cells, then you're going to go to your repeat every 3 years. In the high-grade squamous intraepithelial lesion, or the HSIL, this is going to be classically referred to as the CIN2 or the CIN3, or most importantly, the CIS. So this is usually going to require some sort of excisional procedure for treatment. Ablative procedures can also be offered, but the majority are going to perform excisional procedures to give the pathologist a better specimen to evaluate. So these excisional procedures are going to provide some assurance that an underlying cancer is or is not identified, and that way adequate treatment for the lesion it could be provided. So if we get this like biopsy and we know that this is like cervical cancer, we are confident in like we're treating cervical cancer and this can be treated, or we're confident that it's like not cervical cancer, which is going to give everyone a little bit of peace of mind. Following this excisional procedure, patients are going to require some yearly follow-ups with pap smears. If underlying cancer is discovered, we're going to expand our treatment plans and we're going to get involved with an oncologist. As a primary care provider or women's health nurse practitioner and OBGYN, there are just some things that are out of our scope of practice. If some sort of cancer is identified, it is essential that we refer them to oncology for some treatment and some treatment options. So in this picture, we're having a cervix, and in the cervix, we can identify like CIN1 or the mild dysplasia. We see there's a little bit of abnormal cellular stuff going on, but you can compare it to the normal and just see that there's a little bit of a difference. In CIN2 or CIN3, are moderate dysplasia. You see how those cells start to get a little more abnormal, and you can see how they start to move a little bit into the cervix. Your CIN3 at the top right is going to be what we identify as like the CIS, or this severe dysplasia and carcinoma. And you can just see how those cells on that cervix are just super duper abnormal. And you can just tell by looking at it that something is definitely on. But another good thing about this picture is that you can see the progression of like a normal CIN1, CIN2, CIN3. And so you can see how it progresses. And this is why it's so important that we prevent and we treat our dysplasias, because you don't want it to progress. So let's talk about some patient education. Obviously, we want to educate our patients on lifestyle changes. Safe sex practices are going to be essential in preventing cervical dysplasia. This could be being abstinent from sex, using protection, routine screenings, anything like that. Getting vaccinated against HPV is going to be another like a main factor to help prevent cervical dysplasia. So the Gardasil vaccine is the vaccine that's indicated to help prevent HPV. Boys and girls aged 9 to 26 are going to be who we want to give this vaccine to, preferably before we have any sexual contact or exposure. This is going to help to prevent any cervical or vulvar cancers, as well as any type of like head and neck, penile, anal cancers, or anything like that. Most importantly, routine screening with pap smears and cervical checks is going to be highly recommended. As we talked about earlier in the signs and symptoms, most females don't even know that they have cervical dysplasia unless it's like brought up on a routine pap smear. So for females younger than 21, we really don't want to have any type of screening recommended because we don't want to start messing with their cervical cells that early. However, if they are symptomatic and they are having all these problems and high-risk sexual behaviors, screening might be recommended for them. Women aged 21 to 29, we want to do a cytology without the HPV testing. We can be able to tell if there's going to be any abnormal cells or not. However, at this age, your immune response is going to clear the infection in 8 months or less and decrease viral loads to undetectable levels. For women aged 30 to 65, we're going to do cystology every 3 years or HPV testing every 5 years. For women who've undergone a total hysterectomy that have no history of any type of cervical dysplasia or cancer in the last 20 years, we're not going to recommend them to have some screening because our cervix is typically removed in our total hysterectomy. For women older than 65, we're typically not going to recommend any screening after we've had some prior testing results. So this can include 2 consecutive negative results with negative HPV testing or 3 consecutive cystology results with adequate previous prior screening results. However, if this woman that's age 65 and older does have a prior history of cervical dysplasia, any type of cervical carcinomas, adenocarcinomas, or anything like that, we're going to continue routine screening every 3 years for 20 years. We just want to make sure our cancer doesn't spread or anything like that. So here's my references. If you guys have any questions, feel free to reach out to me, and I hope this presentation was beneficial for you.